achieve complete remission. And if we are struggling with the multiple doses of cyclophosphamide and cycles of rituximab, then the last resort is hematopoietic cell transplantation. So bone marrow transplant has got a significant role in a lot of inflammatory conditions, but more important in lupus, especially the lupus with C1q antibody, which is relatively, it's very, very rare, but it's relatively common in Pakistani and Indian population, among all the Asian populations when it comes to systemic lupus. And we are the only center in the whole world where we have transplanted 2 patients of C1q deficiency with bone marrow transplant, and no surprise, both patients are Pakistani origin, 3rd generation Pakistani origin. And they are doing extremely well after bone marrow transplant. They are off complete medication. So you have to consider these patients were taking 3 or 4 DMARDs, regular steroids, regular rituximab with cyclophosphamide, and now after transplant, 2 years after transplant, there are no medication. So their life is completely transformed, and they are living just normal and healthy life. Again, this is something to be considered very, very carefully for the select group of patients. And I can't emphasize more that we need to be mindful of sepsis, especially in our setting in Pakistan. The second disease group I wanted to talk today is juvenile dermatomyositis. So again, that's a condition which is, I would say, probably a little bit underrated in both dermatology and rheumatology world. A lot of people talk about lupus, and there's a lot of research about lupus and periodic fevers and vasculitis. However, JDM can be as significant as lupus. It can be as multisystem as lupus, and it can cause end organ damage as lupus as well. However, the difference between lupus and JDM, almost always JDM patients usually go to dermatologists or their primary care pediatricians first because of their relatively insignificant signs of rashes before they develop systemic inflammatory symptoms. So very important to get familiar with these signs and symptoms. So here you can see typical rashes associated with JDM, and I will explain them one by one. So you can see periorbital edema and classic heliotrope rash in a young girl with juvenile dermatomyositis. She presented to us 6 months, 6 to 9 months having been seen in primary care, and then she came to us with classic signs. And the reason she got referred to us was constant limping, and she wasn't referred to us because of her skin problems or muscle weakening. She was referred to us because of joint pains and falling over easily, and obviously this was because of proximal muscle weakness. This is a shawl sign, and in severe JDM you can see a shawl sign which represents the anterior chest wall vasculitis. So you can see that it's exactly where girls will take the shawls at the buttocks. Here you can see anterior surface vasculitis in juvenile dermatomyositis, and if you see closely, you can see the fullness of oligrenin process around the elbow, which means that the child's got associated arthritis as well. A bit difficult to see, but very, very, very subtle Gottron's papules in patients with severe JDM as well. Now, this is something that we do routinely in our clinic. So almost every patient that we see in our in rheumatology clinic, we look for their nail fold capillaries. It's a relatively simple investigation, straightforward investigation. You can use it, you can do it with any, you don't have to have a dermatoscope. You can use it with the alcohol gel as a magnifier and use any ophthalmoscope or otoscope that you have available in clinic. And if you see normal, so these are all abnormal, but the normal nail fold capillaries will just look like normal linear capillaries. Here you can see, the pointer is not working, but the on the right-hand corner on the top, you can see dilated vessels with the hemorrhages. There are lots of hemorrhages on the next slide, And on the third slide, you can, on the bottom slide, you can see dilated capillaries, and on the last slide, you can see neovascularization. So that's very common in JDM as well as lupus and many other conditions. So it basically signifies that this patient will have symptoms of Raynaud's, but it can't be primary. It is secondary Raynaud's, usually associated with underlying systemic inflammatory condition. Fortunately, science has improved significantly, and nowadays we have availabilities of lots of medication, including biologics, so we don't see these pictures anymore. So these are historic pictures, but you can see lots of calcinosis, infected calcinosis in these pictures, and inflamed muscles on the histopathology picture. So JDM is also an autoimmune condition where primarily it affects the blood vessels, and as we know, the blood vessels are everywhere in the body, so it causes, primarily it causes muscle and skin inflammation, but as I said earlier, that it can involve any organs in the body. It can be life-threatening if it involves bulbar muscles, because there is a risk of choking and aspiration if bulbar muscles are involved. Incidence is more common in females compared to males, and the incidence across in the Caucasian population is 2 to 3 children a million. As far as I remember, I think the incidence is higher again in Asian and African population. In terms of signs and symptoms, usually they present in 2 different ways. A distinctive rash involving skin, pinkish, purplish, heliotrope rash that we've seen pictures before, usually affects the face and eyelids and hands. Rarely some of these patients present to renal clinics because of their periorbital edema mistaken for nephrotic syndrome and renal failure. Guttern papules is the second type of skin presentation, and it can almost resemble allergies, eczemas, and Fifth disease. Muscle inflammation causes muscle weakness, large muscles around the neck, shoulder, and hips, and most of the time it's proximal muscle weakness in children. So children will, in JDM, so people will present to you with unable to comb their hair, unable to reach to the objects, finding it difficult to walk on the stairs, and if you do the famous Gower sign, they will be unable to sit from all the 4, which I struggle to stand up from sitting position in all the 4, but that's not because I have proximal muscle weakness, that's because I have big tummy. So when Amjad asked me for this conference today, one of my interests was to find somebody quietly and discreetly who can perform liposuction, and I go home as a transformed, a smart person. So children can present with unexplained irritability, weight loss, and mouth ulceration. Like lupus, JDM is also quite difficult to diagnose, especially if they don't have classical signs. So historically, people have used Bohan and Peter diagnostic criteria, where you can define both JDM and just proximal myopathies. So you have to have rash and 3 out of 4 criteria to call it a juvenile dermatomyositis, and we all know that JDM can present without any rashes, so that would be that would be just polymyopathy or polymyositis. However, when we look at this criteria in our cohort studies, so in this study, McCann et al. Is the international leader on juvenile dermatomyositis, and she is one of my colleagues. So our center is very heavily involved and one of the leaders in the whole world, not just in Europe, in the research for JDM. So none of these criteria is actually universally abnormal in JDM. You can see that up to 72% usually have symmetrical muscle weakness. Even muscle biopsy is not as significant because it's very, very dependent on where you take the biopsy and how much inflammation, because in the advanced JDM, your muscle enzymes can be normal and you only see fibrosis rather than active inflammation in the muscles. EMGs are not very commonly used nowadays because the stir MRIs are very, very good. So we tend to take stir images of fat suppressed images of thigh MRI, and that's usually very helpful in diagnosing JDM. We only do muscle biopsies and EMG where we really struggle to get to the diagnosis. And almost 20% of patients usually have a normal CK despite ongoing disease activity. Now, What about the muscle enzymes? As I said earlier, that a lot of about 20% of patients with JDM will have normal muscle enzymes. But if you check all the enzymes related with muscles, then we can increase the diagnostic yield up to 89% with the maximum sensitivity in aldolase. So we tend to do the whole muscle enzymes in the difficult JDM patients. This difficulty led us to develop a project called SHARE project. So that's single hub and access point for pediatric rheumatology in Europe recommendations. So from this, we have combined 15 leading centers in Europe and we have to call Britain as after Brexit as not a part of Europe. So within these centers, we are developing shared guidelines, which should be available for any of you to download from SHARE website, and that involves the rarest rheumatology conditions with no consensus treatment guidelines and consensus diagnostic guidelines. So these are the recommendations from SHARE when it comes to diagnosis of JDM. So the important thing to remember, in the absence of cutaneous signs and failure to respond as expected to therapy, an alternate diagnosis should be considered. And that should be right for any condition, any disease. If you are not getting, despite right treatment, if you're not getting the responses, you always have to think about what are we missing here. Is it not, is it something else, or is just an aggressive trait of the same condition? And the following investigation should be considered where JDM is considered. And a lot of these investigations are reserved for more difficult cases. In terms of management, systemic steroids and physiotherapy is the mainstay of treatment. And unlike many other systemic inflammatory conditions, JDM patients usually stay on systemic steroids in the forms of intravenous methylprednisolone for at least 6 months, if not for 9 to 12 months. And then they stay on the systemic steroids for much longer than other systemic conditions. Many children need other drugs to suppress the inflammation and wean off steroids. So we use, obviously, all of us use DMARDs to wean off the steroids. In terms of DMARDs, methotrexate and MMF is the most commonly used. Cyclophosphamide is usually reserved for end organ involvement, such as lungs or the kidney. Azathioprine is not as effective as it's in the lupus. This should be in IVIG, obviously, because I'm not in a obstetric meeting. So this shouldn't be read as in vitro artificial fertilization. This is my typo error. So intravenous immunoglobulins are very, very good treatment for lupus. We tend to keep children on monthly immunoglobulin replacement therapy for at least 6 months, and this helps to wash out the autoantibodies from the body very quickly. In a life-threatening cases, we use plasma exchange, and plasma exchange is again both in JDM and lupus patient is a life-saving treatment. In terms of biologics, the only biologic that has shown significant results is infliximab. So although we don't use infliximab in many